Here's a number that stopped me cold the first time I saw it in print. More than 50,000 Americans over 65 die every year not from their underlying disease, but from surgical complications. Published in The Lancet, peer-reviewed, replicated across multiple health systems on multiple continents. 50,000 people annually. And the average pre-surgical consultation that precedes those decisions lasts less than 15 minutes. I am Dr. Wei Jiaming. I am a geriatrician, a physician whose entire specialty exists to answer one question. How does the aging body actually respond to medical intervention? Not in theory, not in a 45-year-old. In the 74-year-old managing 4 conditions, 3 medications, and a body that has been working hard for a very long time. I do not operate. I have never operated. My scalpel is a comprehensive geriatric assessment, a structured, full-picture evaluation of an older patient's physical reserves, cognitive baseline, nutritional status, functional capacity, and social support. It takes 90 minutes. It produces a clinical picture that most surgical consultations never come close to assembling. And what that picture shows me, repeatedly, is this. Patients are being sent to operating rooms with information gaps that their surgeons may not recognize, and that their patients have no way of knowing exist. I have spent 24 years as a geriatrician, the last 12 embedded in a major academic surgical center specifically to evaluate elderly patients before high-risk procedures. I have sat in more pre-surgical family meetings than I can count. I have delivered more post-surgical news than I ever expected to when I chose this specialty. What I'm about to share is not theoretical. It is what I see every week. When a surgeon evaluates a patient for an operation, they are assessing a specific problem. Is this anatomical issue fixable? And can this patient survive the procedure? That is a legitimate and important question. But it is not the only question. And for patients over 65, it may not even be the most important one. When I evaluate the same patient, I am asking something different. Does this person have sufficient reserve, biological, cognitive, functional, nutritional, to not just survive the operation, but to come out the other side as recognizably themselves? Those are 2 profoundly different questions. Here is a framework I use in clinical practice that I want you to understand before we discuss any specific surgery. I call it the 3 cliffs. The first cliff is the surgery itself, the anesthetic load, the blood loss, the physiological shock of the procedure. Most surgical risk discussions stop here. The second cliff is the immediate recovery, the ICU days, the ventilator weaning, the post-operative infections, the blood clots, the delirium that sets in on day 2 and sometimes doesn't fully lift for months. Surgical consultations mention this cliff briefly, in passing. The third cliff is what I call functional return, whether the patient regains the independence, cognition, mobility, and quality of life they had before. This cliff is almost never discussed at all. In a 45-year-old, all 3 cliffs are usually manageable. In a frail 80-year-old, each cliff is steeper than the last. Surviving the first does not guarantee surviving the second. Surviving the second does not guarantee clearing the third. My job, the geriatrician's job, is to map all 3 cliffs before anyone picks up a scalpel. And the surgeries I'm about to describe are the ones where the third cliff is most frequently invisible in the consultation room. I put this first because in my experience, it generates the most preventable tragedies, not because of surgical error, but because of delayed presentation. Emergency abdominal surgery in patients over 75 carries mortality rates between 30 and 50% in the most severe cases, according to data from the American College of Surgeons' National Surgical Quality Improvement Program. And unlike most surgeries on this list, you don't schedule it. It finds you. But here is what my geriatric training has taught me that pure surgical training often misses. Most abdominal emergencies in older patients are not sudden. They are slow-moving problems that cross a threshold. The perforated bowel was a partial obstruction for weeks. The ruptured vessel had been a narrowing for months. The acute abdomen had been a grumbling one for longer than anyone admitted. Older patients, and I say this with complete empathy, not criticism, frequently minimize symptoms. They grew up in generations that did not complain about the body. They don't want to be a burden. They assume pain is simply part of being older. And so the early warning that could have led to a scheduled, prepared, optimized procedure instead becomes the 2 a.m. emergency room admission. From a geriatric standpoint, the intervention here is not surgical preparation. It is cultural. It is giving older adults and their families explicit permission to take symptoms seriously and present early. Persistent abdominal discomfort, unexplained changes in bowel habits, or significant bloating in anyone over 60 warrants prompt medical attention. Not next month, not after the holidays. This week, in my years embedded in a cardiac surgical program, I have seen a pattern that troubles me deeply. The frailty assessment, a validated clinical tool that measures muscle strength, walking speed, exhaustion, weight loss, and activity level, and that powerfully predicts surgical outcomes in elderly patients, is performed routinely at fewer than 40% of cardiac surgical centers in the United States, according to research published in the Journal of the American College of Cardiology. Fewer than 40%. Despite decades of evidence that frailty status predicts post-cardiac surgery outcomes more accurately than age alone, more accurately than ejection fraction alone, more accurately than almost any single clinical variable we have. Why isn't it universal? Partly because it adds time. Partly because it sometimes produces answers that complicate the surgical pathway. And partly, and I want to be honest about this, because the financial and institutional momentum toward high-complexity cardiac surgery is substantial. Here is what open bypass surgery does to an elderly body that frail patients are rarely told in plain language. Your heart is stopped. A machine breathes for you and pumps your blood. That machine, for hours, is doing the work of organs that in your body have been running continuously for 7 or 8 decades. The neurological consequences alone, post-operative cognitive dysfunction occurring in roughly 1 in 4 patients over 60, per the British Journal of Anesthesia, represent a quality of life cliff that most surgical consultations describe in a single sentence, if at all. Catheter-based cardiac procedures now exist for many of the conditions that once required open surgery. For appropriately selected elderly patients, outcomes data is strong. Catheter-based intervention is available at most major cardiac centers. What I tell families, before any elderly relative agrees to open cardiac surgery, insist on a formal frailty assessment first. If the center doesn't offer one routinely, ask for it explicitly. If they're unfamiliar with why you're asking, seek a second opinion at an academic cardiac center. The United States performs spinal fusion surgery at a rate approximately 5 times higher than comparable high-income nations, according to systematic review data published in the Spine Journal. No corresponding difference in back pain outcomes exists between high surgery and low surgery countries. I want to sit with that for a moment, because from a geriatric medicine standpoint, it is remarkable. The procedure that carries documented complication rates above 40% in patients over 65, blood clots, infection, hardware failure, and the progressive mechanical deterioration of spinal segments adjacent to the fusion, is being recommended at 5 times the rate of countries with equivalent medical sophistication and equivalent patient outcomes. What drives that variation? Physician training, institutional culture, available technology, and economic incentives that are rarely visible to the patient sitting across the desk. Here is the geriatric dimension that almost never enters spinal surgical consultations. Spinal fusion in an elderly patient does not just carry procedural risk. It carries post-operative delirium risk, the acute neurological confusion that develops in 15 to 50% of elderly surgical patients after major operations, depending on baseline vulnerability factors. It carries prolonged immobility risk during recovery, which in older patients accelerates muscle loss, increases clot formation, and can permanently reduce functional independence. And for chronic non-emergency degenerative back pain, high-quality evidence shows that structured physical therapy combined with targeted injection therapy produces equivalent long-term pain relief in most patients. There are genuine spinal emergencies, cord compression with progressive neurological loss, loss of bladder or bowel control. These require prompt surgical intervention, but chronic pain alone in an elderly patient with multiple health conditions is almost never a surgical emergency, even when it is framed as one. This is the conversation I dread most, and the one I believe matters most. When a patient receives a cancer diagnosis, the emotional imperative to act, immediately, decisively, aggressively, is not irrational. It is human, and in many patients, it is clinically correct. But there is a concept in geriatric oncology that the broader medical system has been slow to operationalize: For elderly patients with significantly diminished physiological reserve, aggressive surgical resection can produce what the literature calls a pyrrhic outcome. The tumor is removed. The patient does not recover from the removal. Research published in the Journal of Clinical Oncology found that elderly patients who experienced major post-surgical complications after cancer resection frequently failed to return to preoperative functional status, even among those who survived the hospitalization. The surgery succeeded. The patient's quality of life did not. A comprehensive geriatric assessment before major cancer surgery changes treatment recommendations in a clinically meaningful percentage of cases. Studies from European oncology centers, where geriatric oncology as a subspecialty is more integrated than in the United States, show that pre-surgical geriatric evaluation leads to modified or alternative treatment plans in 30 to 50% of elderly cancer patients assessed. Modified, not abandoned. The conversation is not surgery versus nothing. It is what combination of treatments gives this specific patient, with this specific reserve, the best realistic chance at more good time. Targeted therapies, radiation protocols, and monitored management have advanced enormously in the past decade. For certain cancers and certain patient profiles, they offer comparable survival with substantially better functional outcomes. The question to ask your oncologist directly: has a geriatrician assessed my reserve and functional status as part of this treatment recommendation? If the answer is no, that is a gap in your evaluation, not a minor one. Hip and knee replacements are, for the right patient at the right time, genuinely transformative. I have seen patients go from near immobility to full functional independence. I believe in these procedures. What I do not believe in is scheduling them on patients whose chronic conditions have not been meaningfully optimized first. Elective means planned. Plan means you have time. Time that the institutional pressure to fill surgical calendars will not naturally use for your benefit, but that you can claim for yourself. A study published in Anesthesiology found that patients who completed a formal medical optimization program before elective orthopedic surgery experienced complication rates nearly 30% lower than comparable patients who proceeded directly. Blood pressure control, hemoglobin A1C reduction, cardiovascular stabilization, nutritional supplementation where indicated. These are not bureaucratic delays. They are the physiological preparation that transforms a high-risk surgical candidate into a reasonable one. From a geriatric medicine perspective, the preoperative period is also the time to assess and address something that surgical teams rarely evaluate: frailty indicators. A patient who walks slowly, has lost weight unintentionally, and reports persistent exhaustion is not simply an older patient. They are a patient whose reserve is compromised, and whose recovery trajectory will look entirely different from a robust patient of the same age undergoing the same procedure. Deep vein thrombosis remains the most dangerous immediate postoperative risk. In elderly patients with reduced peripheral circulation, clots that travel from the legs to the lungs can be fatal. This risk is not mentioned with sufficient specificity in most preoperative consultations. If your surgical team has not discussed a prehabilitation or optimization program before an elective joint procedure, ask for one. If they can't explain why your specific chronic conditions are adequately controlled for surgery, request a pre-surgical geriatric evaluation. Many major orthopedic centers now offer this. Many more should. I want to name this as a category of risk in its own right, because in 24 years of geriatric practice, it has caused as much harm as any technical complication. Inadequate informed consent in elderly surgical patients is not primarily about paperwork. It is about whether the patient and family genuinely understood, not just heard, but understood, what the realistic post-operative trajectory looks like for their specific situation. Research published in JAMA Internal Medicine found that a significant percentage of elderly patients who underwent major surgery reported that they had not been clearly told there was a possibility they might not return to independent living afterward. Not that they forgot, they were not clearly told. The gap between surviving surgery and returning to the life you had is the central gap that geriatric medicine exists to address. Surgeons are trained to close anatomical problems. Geriatricians are trained to ask whether closing that anatomical problem will leave the person more whole or less whole than they were before. Both perspectives are necessary. Currently, in most surgical centers, Only one is consistently present in the room. The regional variation dimension compounds this. Surgical recommendation rates for identical diagnoses vary by a factor of 2 to 5 across different U.S. regions, documented across joint replacement, spinal surgery, cardiac procedures, and cancer resection alike. The recommendation you received reflects, in part, where you happen to live and which system you happen to have entered. A second opinion from a major academic center, particularly one with an integrated geriatric oncology or geriatric surgery program, is not an act of distrust. It is rational, evidence-based self-protection. As a geriatrician, I don't give patients vague advice. I give them specific things to look for. Here is your checklist. If any of these apply, slow down and seek a second opinion before signing anything. Red flag 1. No one has performed a frailty assessment. Frailty status is one of the strongest predictors of surgical outcome in patients over 70. If your team cannot tell you your frailty score, or doesn't know what you mean when you ask, your preoperative evaluation is incomplete. Red flag 2. The consultation lasted under 20 minutes. A decision that may alter your functional independence permanently deserves more time than a routine follow-up appointment. If it didn't get that time, the process did not serve you. Red flag 3. Your other health conditions were not discussed in specific detail. A surgical recommendation that doesn't account for your kidney function, cardiac status, current medications, cognitive baseline, and nutritional status is not a recommendation about you. It is a recommendation about your primary diagnosis, detached from the person who has it. Red flag 4. No one asked what you want your life to look like after recovery. This is the question geriatric medicine always asks first. If it was never raised, the consultation was procedure-centered, not patient-centered. Red flag 5. You were told this is your only option. In 2025, across virtually every major surgical category, alternatives exist. Only option is rarely accurate. When you hear it, probe it specifically. Asterisk, what is the evidence for this being my only option given my age and health profile? Asterisk red flag 6. A second opinion was discouraged. Any surgeon confident in their recommendation should welcome external review. Discomfort with a second opinion is a signal worth taking seriously. Red flag 7. No prehabilitation or optimization plan was discussed before an elective procedure. For any non-emergency surgery in a patient with multiple chronic conditions, pre-surgical preparation should be standard. If it wasn't mentioned, ask for it by name. I want to be precise about what I am and am not saying. I am not saying avoid surgery. Surgery saves lives every single day, and I have been at the bedside when it has done exactly that. I am saying that the surgical consultation, as it currently functions in most settings, is built around the surgeon's expertise and the procedure's feasibility. It is not routinely built around the whole older patient, their reserves, their priorities, their definition of a life worth living after the operation. That gap is not malice. It is structural. Surgeons are trained to operate. They are not always trained to assess frailty, project functional trajectories, or facilitate the kind of goals of care conversations that geriatric medicine considers foundational. The answer to that structural gap is not patient suspicion of doctors. It is patient-doctor partnership that actively closes it. What that looks like in practice. You arrive at the surgical consultation with specific questions. You ask for a frailty assessment if one hasn't been offered. You request enough time to understand not just the procedure, but your personal post-operative trajectory. You ask about alternatives. You seek a second opinion when the stakes are high, not because your surgeon is wrong, but because certainty in medicine requires more than one perspective. And ideally, you have a geriatrician in your corner, either as your primary internist or as a consultant your surgical team brings in. Not every patient has access to one, but every patient can ask their primary care physician, asterisk, can someone evaluate my overall reserve before I commit to this surgery? Asterisk that question, asked plainly, opens a door that the system doesn't always open on its own. The best surgical outcomes I have witnessed in 24 years have one thing in common. They were not the most technically impressive procedures. They were the ones where the surgical team and the patient, and sometimes a geriatrician in the room, had a real conversation before the first incision. A conversation about risk, about recovery, about what this specific person needed their life to look like on the other side. That conversation is not a luxury. For patients over 60, It is the standard of care they deserve, and the one they should insist on receiving.